Well, thank you very much. I have to say it's a little intimidating to stand out here in front of 5,000 of you, and I hope you'll exercise a little patience if things get a little freaky here today. I want to take a minute just to mention Dr. Weil and his contributions to this society. I feel very fortunate and very honored to have the opportunity to stand up here and present in front of such an austere group and to be recommended to do so by the organizing committee. But I have to remember that much of what I am going to discuss with you has really been made possible by the efforts of this one individual. Much of what we do in the ICUs really is built on the foundation that Dr. Weil created 25 years ago. So with that, let me move forward and start this presentation. First of all, the financial aspects, there are no conflicts of interest. I don't promulgate the off-label use of any drugs. And all of the research that I'm presenting here was funded by the National Institutes of Health during this past 25 years of funding. If I was going to give this talk 15 years ago, 10 years ago, I'd be disappointed, and it would be a rather negative talk. Because if you look at the history of mortality to severe sepsis, what you actually see is that in that period between 1989 and, say, 2001, 2002, there were actually very little improvements in the long-term outcomes of survival to sepsis. And this is somewhat ironic, since the 1980s were the heyday of sepsis research, with the cloning of TNF and the cloning of IL-1 and the development of all these phenomenal drugs for inhibiting the inflammatory response. And if you look at the impact that they've had over that period, it's been very, very modest. The number of failed interventional trials in patients with sepsis has been over 300 to date. And the question is why? Why have we failed over this period while we've obtained such an improved understanding of the biology? Now, the reason I said that if I gave this talk 10 to 15 years ago, I would be depressed, because something has happened in the past 10 years. And it's shown really in this slide, is that this is just one of several studies, but the important findings are that since really 2001 to 2002, we've seen a progressive decline in inpatient hospital mortality from severe sepsis. And this is during a period when all of these clinical trials with biologics have failed. And so the question really is, what can explain this progressive improvement in in-hospital survival in patients with severe sepsis that have occurred over the past 10 to 15 years? And I'll make the strong argument that it was this society and this membership who took the leadership in developing early recognition and standardized guidelines for improving outcome to sepsis. Initiated in 2002 at the Barcelona Declaration was the Surviving Sepsis Campaign. And the Surviving Sepsis Campaign has actually been very, very simple. And in 15 years of retrospect, it's almost been obvious. It says recognize sepsis early, intervene early. Standardize best of care treatments. This is a study published in Critical Care last fall, which just sort of summarizes a meta-analysis over the past 10 years with goal-directed therapies. And what it's shown is that goal-directed therapies can significantly reduce overall mortality in patients with sepsis, especially when those therapies were initiated early, after early recognition of sepsis. Studies by Drs. Levy and Dellinger, from this society, published this week in Critical Care Medicine. Results from the first 7 years of the Surviving Sepsis campaign has shown that as these programs are implemented, survival to sepsis progressively increases. And what's really interesting and important about this is that merely small increases in compliance, increases from 10 to 25% in the resuscitation bundle, from 15 to 25% in the management bundle, have all resulted in dramatic improvements in in-hospital mortality. It's ironic. Think of the irony here. There have been 300 clinical trials with biologics. Over $4 billion in industry money has been spent to intervene in early sepsis and to prevent organ failure and death. And they've all failed. Every drug has failed. And yet, we're seeing an improvement in early management, that early recognition, standard of care, best practices developed by this society has resulted in significant improvements in outcome, in hospital outcome. The challenge now is to understand whether we're making the long-term impacts that we're seeing in in-hospital mortality. Are these benefits that are being recognized by improved recognition of early sepsis, improved interventions and best care practices, are they translating into long-term improvements in outcome? This is an administrative database from the University of Florida, from Shands Hospital, that was done by Dr. Bahorek in our department, a K Award recipient from the National Institutes of General Medical Sciences, who studied the administrative database and looked at major surgery patients over a 10-year period, and identified 2,400 out of 50,000 major surgery patients who developed severe sepsis. She looked at those patients who were hospitalized in the ICU for less than 14 days, 9%. She looked at those individuals that died in the ICU from sepsis before day 14, 9%. 82% was in the ICU for 14 days, and ultimately were either died during their hospitalization or were discharged. She followed these patients out and looked at mortality over 10 years and found that if you were in the ICU for more than 14 days with surgical sepsis after surgery, 62% of you were dead by 2 years. So the challenge is, yes, we're doing better in terms of improving in-hospital mortality by earlier recognition, by standard of care, by best practices. But the key question is, are we making long-term impacts on the patient population? I think that's the key question. And now we get into the immunology of severe sepsis. This is a model that was put forth 2 years ago by Fred Moore and myself from the University of Florida. And it was really a modification of the model that was developed by Roger Bone in the 70s, the SIRS-CARS model. And it reflects our newer understanding, newer experimental data in support of it. And what it says is that in response to sepsis, you still have this cytokine storm, here represented by SIRS, and a corresponding immune suppression by CARS. Some patients, in our experience, about 9%, have early multiple organ failure and fulminant death. And then there's a population, about 9%, that has rapid recovery and is discharged. And then there's a group of patients, you've seen them all, who tend to linger in your ICUs, who are hospitalized for over 14 days. And they have ongoing inflammation, and they have ongoing immune suppression, and they have protein catabolism. And the long-term impact of these patients, we don't know. So what has the Surviving Sepsis campaign done? It's essentially attacked this early SIRS response and is blocking the development, the progression of SIRS into early multiple organ failure through an exaggerated inflammatory response, a cytokine storm, blocking the move from multiple organ failure into fulminant death. You individuals are getting better at treating multiple organ failure, and we're having less death. And what we're seeing is a progression, a pushing of our patient population from this early death into this, what we have called chronic critical illness, 14 days in the ICU. Or even worse, this persistent inflammation, persistent immune suppression, catabolism, cachexia, this syndrome that we have called PICS. And so what we're learning is that for the future of the treatment of severe sepsis, there's a continuing need to reduce this inflammatory state, this exaggerated inflammatory state. Early recognition, anti-inflammatory agents, appropriate control. But what we're beginning to see is a much larger population, especially in the aged, of these patients with chronic inflammation and immune suppression that are sitting in your ICU. It's under-recognized. Whether they need immunoadjuvants or anti-inflammatory agents or anti-catabolic agents, we have this group of patients. I would challenge you to go up to your ICUs and just look. They're there if you look for them. How do we define this syndrome? It's persistent, 14 days in the ICU. There's chronic inflammation, elevated CRPs. There's evidence of immune suppression, reductions in absolute lymphocyte count, reduced HLA-DR expression, increased protein catabolism, patients who get weaker as you look at them, losing lean body mass, inability to get off the ventilator. These patients have prolonged ICU stays. They have manageable organ dysfunctions, recurrent infections, including viral reactivation, persistent acute phase response, poor wound healing, decubitus ulcers, and their disposition is rarely to home. It's usually to LTACs or to specialized nursing facilities. What's interesting about this syndrome is that it's a common syndrome. It's remarkably similar to the pathogenesis that you see in patients with advanced cancer. They're immunosuppressed. They have chronic inflammation. They have protein catabolism, cancer cachexia. And they have dismal outcomes, very much like the protracted infection, the patient with PICS. So I ask you, do we have chronic critical illness and PICS in our post-sepsis patients, especially our elderly? We would say that in our institution, up to 82% of our patients who experience severe sepsis after surgery or after trauma in our surgical and trauma ICUs remain in the ICU for longer than 14 days. They have persistent inflammation. All it takes is a look at the C-reactive protein levels. Normal is less than 6. These patients that are there for 14 days, 150 to 200. Absolute lymphocyte counts and evidence of a dyscrasia at the bone marrow level and a removal of lymphocytes from the blood. Normal being greater than 1.2, 1.3. These patients traditionally have low levels. A neutrophilia, that's always been seen. But let me tell you, and I'll show you later, these aren't your grandmother's neutrophils. Sepsis patients have an unusual phenotype of neutrophil population, and we'll talk more about those and how they contribute to this syndrome. Do they have immune suppression? Obviously they do. This is a study recently from Richard Hotchkiss's group looking at patients who have protracted sepsis and the reactivation of viruses. What's interesting here is that as many as 50% of the hospitalized patients who are ICU bound for 14 days with sepsis will have reactivation of viral infections. And if you look at the timing, if they're going to have reactivation, 14 days. If you look at persistent lymphopenia, this is again more data from Hotchkiss. All it takes is 4 days of persistent lymphopenia to separate you, to distinguish you in terms of what your long-term outcomes are going to be. 4 days of a absolute lymphocyte count of less than 0.6, you have over a 50% chance of mortality. You restore your lymphocyte counts back towards normal, and your risk of mortality is significantly less. I don't need to go through the literature or the history to show you that there is evidence going back 40 years to the failure to mount a delayed type hypersensitivity response. That these patients are immune suppressed. Persistent catabolism. This is almost taken for granted. The patient laying in bed with sepsis for 14 days, on a ventilator, unable to be weaned. Do they have persistent catabolism? We've started a program at Shands where we are doing ultrasound determination of cross-sectional analysis of the diaphragm and the vastus lateralis. And we're looking at the changes over time. And the numbers are staggering. 4 weeks, 2 weeks in the ICU with sepsis, 20 to 30% reductions in cross-sectional area of muscle mass. By 4 weeks in the ICU, these patients have lost 50% of their cross-sectional muscle mass. So let's go back to this. What we're arguing is that as we get better in our early recognition and our early management of these patients with severe sepsis, we're developing a new set of issues. And that is this persistent population of mostly elderly patients in our ICU who have persistent inflammation, persistent immune suppression, persistent catabolism, and they have lousy outcomes. And so here's the question, and it's probably the most important question in this talk, is what drives this syndrome? What is the propagation of PICS in this chronic critically ill patient population? Hopefully, the initial septic event you've covered with microbial support. You've gotten these patients through their initial event, and yet they're cooking in the ICU. Now, we would argue that this represents a vicious cycle. A cycle where inflammation drives immune suppression. Immune suppression results in increased inflammation through activation of secondary infections. And that inflammation leads to protein catabolism. Protein catabolism leads to protein malnutrition, which leads to immune suppression. And you get this vicious cycle. How could inflammation lead to immune suppression? Sounds counterintuitive. But there's a large body of data showing that inflammation, and especially induction of type 1 and type 2 interferons, suppress the inflammasome, which is involved in recognition of innate immunity. Suppresses RNA protein synthesis, suppresses lymphopoiesis in the bone marrow, stimulates the upregulation of checkpoint inhibitors, stimulates the release of immunosuppressive cytokines. Kevin Tracy would tell you that the neuroinflammatory reflex, the signaling between the brain and the immune system, is activated. Not only does it suppress innate immunity, but it also suppresses effector cell function. All these functions lead to immune suppression. Then you have an immune suppressed patient. And the question is, are those patients at higher risk of secondary nosocomial infections or viral reactivation, which then causes the release of PAMPs, DAMPs, activation through toll and LR sting RIG pathways. Viral reactivation again. And that feeds the cycle. The other approach, one that we've argued about, gets back to those neutrophils. It says that those neutrophils are not the same neutrophils that are circulating in you and I and in healthy individuals. But these are immature myeloid-derived cells that have both inflammatory and immunosuppressive potential. What are these cells? And this gets back to the cancer story and to other chronic inflammatory states. What we know is that injury, infection, tumor growth, all sorts of inflammation stimulate the production of early bone marrow progenitors. And yet the lymphoid pathway is completely turned off. So part of the reduction in absolute lymphocyte count that you see is due to the absence of lymphoid progenitors. What you see is a massive increase in myeloid progenitors. And these myeloid progenitors differentiate until they become immature monocytes, immature neutrophils, a population that we have called myeloid-derived suppressor cells. And for reasons we don't know and understand, they don't mature into functional granulocytes, macrophages, or dendritic cells. This is why, when you look at septic patients, part of the reason why they have reduced numbers of these cell populations. What's even worse is that these myeloid-derived suppressor cells arise and have both inflammatory and immunosuppressive properties. For example, they produce reactive nitrogen species, which are both pro-inflammatory and are also involved in the nitrosylation of the T-cell receptor, preventing adaptive responses. They produce reactive oxygen species. They actually can kill T-cells by contact. They suppress T-cell proliferation. And really, it was Phil Efron in our group who was really the first to show that in sepsis, there's a massive increase in these cell populations. This little tiny blue dot, group of blue dots here is you and me. We have about 0.1 to 0.5% of our cells are myeloid-derived suppressor cells. After sepsis, it increases to 30 to 50% and even stays elevated out 4 weeks, out to about 10%, a 50-fold increase over what's seen in normal states. What's interesting about these cells, now if you take these cells, I take them from you and I take them from a septic patient, they look exactly alike. I've sorted them based upon their cell surface molecules, so they look like each other. But if you look at these cells functionally at the level of the genome, the transcriptome, you can see their massively increased activity in terms of adhesion molecules, proteases, granular secreted proteins. These cells are cooking inflammation. And at the same time, they've shut down their ability to present antigens and to drive adaptive immunity. So not only do we have 50 times more of these cells in septic patients, but their ability to suppress CD4 and CD8, these are T helper cell populations, is markedly increased from about 60% suppression at a 2-to-1 ratio, 60 to 70%, to 83 to 90%. And in fact, it tends to kill CD8 cells. So not only do you have 50 times more of these cells in the blood of patients, but you also have them more functionally active. So what are the take-home points? 1, here they are. In-hospital mortality is improving to severe sepsis, and the credit goes to the people in this room. Due to programs like the Surviving Sepsis campaign that support earlier recognition of sepsis and intervention with best practices. We know we're improving in-hospital mortality. What we don't know is whether we're improving long-term outcomes. And especially in our aged, more of our sepsis survivors are surviving this early inflammatory insult, but they're exhibiting these prolonged periods of persistent inflammation, persistent immunosuppression, protein catabolism, and unfortunately, we're still seeing long-term dismal outcomes. So, where do we go moving forward? What we now know is that interventional therapies will need to be targeted to individual patient populations depending upon their phenotype. Obviously, the therapies for early sepsis during that cytokine storm will not be the same therapies for the patient who's been in the ICU for 14 days and has persistent immunosuppression and inflammation. And so there's a compelling need for the development of interventional therapies that could shorten or reduce the consequences of this chronic critical illness in these patients who survived the early sepsis storm. So if we go back to our model of how this PIC syndrome is propagated, we can see that it's highly likely that we're going to have to be targeting multiple points. There are people in the audience who will tell you that all you need to do is block the immune suppression with a variety of different approaches. If you block immune suppression, then you should block nosocomial infections, you should block viral reactivation, you should block the subsequent inflammation and break this vicious cycle. That is yet to be proven experimentally. There are people who say, well, you just need to interfere with the inflammatory response. You block the inflammatory response, and then you will suppress the immune suppression. That's been experimentally tested, and the data is not overwhelmingly supportive of that. There are people who say, well, all you need to do is prevent the protein catabolism. You need nutrition, you need exercise, you need anabolics, you need to get them off the ventilator, get them up and walking in the ICU. There's something to that argument. I will take the position here that if we're going to have a significant, long-lasting impact on this patient population, there is sufficient redundancy in these signaling pathways that you're going to have to intervene at all levels simultaneously. We're going to have to think about supporting the adaptive immune system. We're going to have to think about suppressing the chronic inflammatory response. We need to block the protein catabolism, which is leading to muscle wasting and malnutrition. We need to get the patients up off the bed. The other approach, if you want to drink my Kool-Aid, you just have to block the MDSCs, since they're driving both the inflammation and the immune suppression. There are a number of agents which are being tested in cancer, need to be tested in sepsis. So let me end by just saying that thank you for giving me the opportunity to present. I have the opportunity and the privilege of standing up here in front of you, but the data and the work has been done by a large number of people. This is our research group at the University of Florida, and I need to point out just 5 individuals in particular who happen to be members of this society. Fred Moore, Azra Bohorak, Scott Frackenridge, Phil Efron, and Alicia Moore, whose work I've really talked about and whose ideas I've stolen. So thank you very much.